across your cellular membrane, depending upon if you're acidotic or if you're alkalotic, whatever. Sometimes the hydrogen, I know this, I'm putting things in my terms, sometimes the hydrogen will go hide inside of the cell. If you're too acidic out here, the hydrogen's like, oh, it's getting too much, and the hydrogen will go hide in the cell. Well, there's a balance between, potassium is supposed to be your greatest intracellular cation or electrolyte. So the potassium's like, dude, there's too much positive in here. I've got to go. So the potassium leaves. And the potassium is now out here in your extracellular fluid where it's really not supposed to be. And so your kidneys start going, dude, we got way too much potassium. We need to tell the tubules to get that crap out of here. And so you start peeing out the potassium. So you can have an acidosis problem and eventually lead you to a hypokalemia problem because your potassium isn't inside the cell where it's supposed to be because the hydrogen went in there and booted it out. You want that charge to be equal, right? So your cells have the exact amount of positive and negative ions that it needs inside and outside in your extracellular fluid. You've got exactly the amount of positive and negative ions that you need, and everything kind of stays balanced. When you start producing acid, which is secondary usually to carbon dioxide metabolism, but you've got hydrogen ions. Anytime you see hydrogen ions, think acid. Carbon dioxide, think acid. That'll help you kind of keep them straight. So when you start having an abundance of hydrogen ions, your body starts going, yeah, we got to get rid of some of this. So the hydrogen ion actually goes and hides in the cell. Well, then the potassium, who's supposed to be in there, goes, yeah, I don't want you in here, I don't like you, we're both positive, and this just can't happen. So the potassium actually leaves the cell, which now makes it be out here, where it's not really supposed to be. And so your kidneys start going, hey, wait a minute, we got too much potassium swirling around in our blood, we got to get rid of some of this. And it increases that tubular, not reabsorption, filtering of the potassium to get it out in your urine and to get it out of your body. So these two electrolyte imbalances, fluid electrolyte imbalances, and acid-base imbalances go hand in hand. So as you're reading your material and you're like, wait a minute, am I talking about acid-base here, or am I talking about fluid and electrolytes? You're probably talking about both, because they both influence each other very heavily. Okay, so let's get this party started. Before I get this party started, I wore a shirt just for you guys. I waited all year to be able to wear this shirt. And then they moved me to BSN in level 4, and I'm like, ugh, we don't do acid-base and fluid electrolytes in level 4. So this shirt's been sitting there waiting for it. Because if you wear it in the general public, they kind of go, huh? Except people who are in the medical field, they're like, ha ha, okay. Okay, so let's start with K, potassium. Most abundant intracellular cation. So, in the cell. Now you know we still have potassium outside of the cell. There's just a higher concentration of it inside the cell. Conversely, sodium is the most abundant extracellular. Oopsie. My L's got a little close there. They like each other. So these two, sodium's mostly out here, but there is some sodium in your cells. And your potassium is mostly inside the cell, but there's some potassium out here. And they're the things that kind of keep that resting membrane potential where it is. Why is that important to know? We're going to talk about that. So we're going to start with potassium. 3.5 to 5.5. Memorize that, live it, learn it, know it. That's very important for you to memorize. Unfortunately, with your fluid and electrolytes, you just gotta memorize these things. This is what it is. These are where your flashcards are gonna come in handy. Just make some flashcards. If you need index cards, I've got a couple packs in my office. You just have to memorize these values. So with potassium, it's the most abundant intracellular cation. It does require a more aggressive correction, but like if I'm off with my potassium, and it's mostly because it doesn't want to leave where it is. It's a homebody. It kind of just likes to be inside of the cell. But if something has happened and I have too much potassium outside, and you know when we talk about imbalances, we're talking about in the extracellular fluid, right? Not inside the cell. We can't measure inside of the cell. But we can take a blood sample and measure what's going on outside of the cell, because that'll tell us what's going on inside of the cell, because they all have their place and they keep each other in check. When I have too much or too little of one, then the other one's like, woohoo! And the other one starts to kind of run rampant, and because there's nobody there to keep each other in check. They keep each other in check. They're like a perfect little pair. They keep each other in balance. So with my potassium, the biggest thing that it's responsible for is that resting membrane potential in a cell. So as long as my potassium stays inside the cell like it's supposed to, and my sodium is on the outside, that cell is kind of at rest. Whenever we get an action potential sent down from the nerve, or if I have an imbalance, that's whenever those cells get excited and we start to have problems. In particular, your potassium has the greatest influence on your cardiac cells. So the sodium imbalances will affect your cardiac cells, but boy, they are really sensitive to those potassium imbalances. I'm having math issues. All right, so first thing we're going to talk about is hypokalemia. Do you guys understand what I mean when I write it down with a K? And then hyperkalemia is an up K. Not to be confused with an up chuck, which is slang for peak, which I'm sure some of you are going to want to do with this test. Sorry. Okay, so hypokalemia. A lot of times, the hypokalemia is associated with inadequate intake of fluids. And you're going, wait a minute, what? I don't have potassium in my fluids. No. But if I don't drink enough water, my sodium balance starts to become more concentrated, and we don't have a balance anymore. So it can be affected by how much you drink. That's why whenever you're dehydrated, you can get muscle cramps. It is the sodium, but it's also your potassium. Not calcium. GI and renal losses. Again, your kidney patients are going to have problems with their potassium balance, because in your renal, in your nephron, in that tubule, that's where your sodium, your potassium, and your hydrogen ions are rebalanced at the end of that tube before it either goes out to urine or gets reabsorbed back in the blood. One of the two, but it's that little area right at the distal end of the nephron tubule where that exchange happens. And your body's like, okay, we need more sodium, so we hold on to sodium. We don't need as much sodium, so we get rid of sodium. We all know if we get rid of sodium, we get rid of water. Hyperaldosteronism is another cause of hypokalemia. I should be writing these things down, huh? Sorry. Inadequate fluids, GI and renal insufficiency.
What's the very first one say?
Inadequate? Am I right, inadequate?
No.
It's kind of hard. I mean, I'm trying to cram a whole bunch of stuff on the one board. I taught a couple of classes for the dual credit for service learning. So I went and gave the high school students information about service learning. And it was the coolest thing. The whole wall was a dry erase marker board. So you didn't have, I mean, you could like write right here if you wanted to. It was so cool. I was like, this is brilliant. Instead of being confined to this little area, I mean, the whole wall was a dry erase board. And hyperaldosteronism. This is going to be a big word. That sounds like two. Okay. So, hypokalemia, things that are going to cause my potassium levels extracellularly to go down. So how do we treat it? We give them oral potassium, oral potassium, or gradual IV replacement. I'm sure you guys all know this, but you don't ever give more than 10 milliequivalents of potassium IV under a half an hour. They usually want to do it an hour. If you're being real, and it's always mixed in a little 100cc bag. Not only does it burn like fire, but this starts to get jacked up. Even though I have a low value out here, my body's kind of trying to keep sodium and potassium moving along just fine. But if I give it too much potassium, those cellular membranes are going to get super excited. And it's going to cause muscle spasticity. It's going to cause some other issues, especially in here, in this heart. So we do our best to give them oral supplements. I ran out of room. I'm just going to write it right here. That's REPL for replacement. So we're either going to give them oral or IV replacement. But if we give IV replacement, it goes very slowly. And we have to really pay attention to what their heart's doing. Because remember, we're putting it right into their bloodstream, so that potassium is getting swirled around. And those cardiac muscles are very sensitive to that potassium, and they may get all excited and start causing your patient to have dysrhythmia. And we don't want to do that on purpose. Hyperkalemia is not almost always, it's often associated with acidosis. And again, why? Remember I told you. Absolutely. It's associated with acidosis because the hydrogen ions start to jump inside of the cell, which kick out the potassium, which makes me have hyperkalemia. It's also associated with renal disease. Because, why? You guys remember the little nephron, right? Then there's this little distal tube part right here. I know, I'm not an artist. I'm a nurse. But here's my glomerulus. You know, this is your loop of Henle. Here's your ascending, your descending and your ascending, and then you've got this little area right back here. And this is where all of your potassium, sodium, and hydrogen is readjusted based upon what your body needs. So if I have renal disease, my kidneys are either not filtering my electrolytes correctly, they're not filtering my blood correctly, depending upon if I've got damage to these nephrons. If I have completely, like, say with high blood pressure, I've completely fried out 1 million of my nephrons. Granted, we get about 3 million to begin with, but over time, let's just say I've trashed 1/3 of my nephrons. That's going to affect my kidney's ability to do its job. These are the patients that have chronic electrolyte imbalances, if those kidney injury or those kidney patients. Another thing that can cause hyperkalemia is soft tissue trauma. Why do we think that is? Hang on, I'll turn around. I can hear you better. If I start talking while I'm writing, I end up writing what I'm saying, and it's catastrophic sometimes. So, soft tissue trauma. Why do you think I might have hyperkalemia from that? Good job. So, my potassium's supposed to be in here, and I've got a little bit of sodium and some hydrogen ions. But if I crush these, all that stuff leaks out. A little dramatic. So always, 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 if you have a patient who has had some type of soft tissue trauma, you're probably going to have an electrolyte imbalance that you need to look for. Like a lot of soft tissue traumas, and a big muscle group in particular. I mean, I'm not saying like if I have a bruise on my arm, oh my God, I'm hyperkalemic now. Not necessarily. I'm talking like if I've been in a car wreck, and I've got road rash, and I've been crushed here, and I broke my arm. That's a lot of soft tissue damage, and that's a lot of stuff and broken cells that are not supposed to be where they are now. So how are we going to correct hyperkalemia? Do what? K-oxalate. K-oxalate is a good thing. We can also give them, so here's one of those great things where we're using a bad property of a drug to do good. What is something that we give our patients that unfortunately a side effect is low potassium? We give it to all of our cardiac patients. We give it to a lot of our
Lasix.
Lasix! Yay! So when I give my patient Lasix, you know, we have to keep track of their potassium levels, right? Well, if I'm hyperpotassium, if I'm hyperkalemic, hey, let's give them a little bit of Lasix and make them pee, but we're going to get rid of some of that potassium. But unfortunately, it's also going to cause a little bit of a sodium issue too. But hey, you know what? We need to get this potassium down. And bromels. So, I'm going to put Lasix. Another thing that we can do, and again, I'm kind of blurring the lines over here in acid base. So if I have high potassium, a lot of times, like I said, it's associated with acidosis. We correct an acid problem by giving you base. If you don't believe me, the next time you eat too much Mexican food and you have an upset tummy, what do you take? Tums. Tums is sodium bicarbonate. It's a buffer. So you take that buffer to make the acid in your tummy stop churning and burning. So whenever I have a patient who has hyperkalemia associated with acidosis, we can pop some Tums in them. We're giving him some base, and that will eventually get broken down and get out here where it needs to be. Now, this is not going to happen quick. And you do not want to correct a potassium problem quickly. Don't. Because if you do, you're going to cause a whole slew of problems because now we got too much or not enough, or it's being taken away. It's like money. You don't just automatically take away someone's money. It's going to leave them bereft and down. You just take little bits of money away and you never even know. So let's do that with the body. Let's correct this very slowly and carefully. Now, if it's just a little bit, like if my potassium is 5.1, here's some Tums. Drink a lot of water and go pee, you'll get over it. But if my potassium's like 6, probably there's going to be other problems going on if it's that high. But that's when we're going to be a little bit more aggressive, but those patients are in the ICU. So that we can monitor what their heart's doing, and we are sitting there right there with that patient going. So, we correct fluid and electrolyte problems slowly. Mostly electrolyte, not just necessarily fluid. I mean, we can correct the fluid problem pretty quickly, though. Okay, so, you know what? I just don't have enough room. Let's talk about signs and symptoms. This is something you're going to need to know. So with hypokalemia, okay, with hypokalemia, cellular, so I put it in green up here so you guys could kind of walk through it in your brains. So if potassium is responsible for that resting potential, which then leads to muscle function, right? Because if my cells are at rest, I don't have nerve impulses traveling, and I don't have overexcited muscle fibers. If my cell membrane is not at rest, that means my nerves are going, and that's what gives me, room to do this, or to do this, or to have a twitch in my eye because I'm stressed, or muscle cramps, something like that. So with hypokalemia, what do you think, with related to my muscles, what do you think is going to be a sign symptom that I'm going to see with hypokalemia? No fear looking at your PowerPoint. Cramping in the sense of weakness. Not cramping like, oh, Charlie horse!
So what's the Charlie horse called?
Hyperkalemia. And sodium issues. So, muscle cramps in the sense of weakness. You'll get like achy cramps as opposed to Charlie horse cramps. Cardiac dysfunction is also another thing that we're going to see with hypokalemia. And again, it's because that resting membrane potential is not getting as excited as it should be. And you guys know what I'm talking about, right? You've got the cell membrane, you've got the potassium on the inside, sodium on the outside, and when the nerve stimulates that cell, the potassium and the sodium switch places, and that's what allows the nerve impulse to keep traveling down that muscle fiber. That's what starts it. So if I start messing with that balance, that's going to mess up the way the electricity is carried down my muscle fiber. So with hypokalemia, the biggest things you're going to see is muscle weakness, cardiac dysfunction, in the sense that it's not really wanting to do what it's supposed to do, and respiratory failure. But we'll go into respiratory failure more here in just a few minutes. And again, just because I'm at 3.4 doesn't mean I'm going to start having respiratory failure. This is like significant low. I'm just telling you what you're going to be looking for. Because I can tell you right now, your NCLEX, your test questions, everything wants to know is, can you think downhill? Because that's what makes a safe nurse, is a nurse that can plan. If you know that if I correct this potassium too fast, these things are going to happen, that's critical thinking, that's clinical judgment. So you know not to correct potassium really fast, because it's going to make these other things happen that are untoward to my patient's body. So when we talk about respiratory insufficiency and muscle weakness and cardiac dysfunction, those are like your downhill thinking points. So those are the things, because you're great nurses, you're going to go, okay, I'm going to be correcting this, and these are some things that I need to be watching out for in the interim until it gets corrected. That's what clinical judgment, that's what NCLEX is moving towards, is clinical judgment is the most important thing. Because that involves safety, that involves all those other things that we teach you as far as answering NCLEX questions. Yes, there's stuff you just have to know, but there's also patient safety, and can you practice as a safe nurse? That's what NCLEX wants to know. And you do that by thinking downhill. You understand what I mean by downhill? Like think about dominoes, or think about, you know, this is what bleach, woo! If I were to unscrew this and hold it like this, you know what downhill thinking is going to be with this. If I let this go, the bleach is going to spill and we're going to have a big white spot on the carpet. And then they'll be mad at me. So that's downhill thinking. You just have to do it to your patients. I know, this is a lot of information and it's coming happy and fast. All right, so potassium, hypo and hyperkalemia. If I have a patient that has a really high potassium and I really need to fix this like pretty quickly, I'm going to do dialysis on them. Because dialysis, as you all know, bypasses this. And you know, I've only got this little area right here that's doing all this exchange of potassium and sodium and hydrogen ions. But if I do dialysis, by God, we can take a whole classroom of potassium and get rid of it. But keep in mind, dialysis is very hard on your patient. It is very hard because you're adjusting things very quickly. And if your patient is not hemodynamically stable, they might be candidates for like CRRT or another kind of dialysis. CRRT is like dialysis light. And that's pretty much exclusively what they use over in Europe and the United Kingdom because it's easier on the body. You can still adjust things kind of aggressively, but it takes longer and it's a little more kind to the body. Normal hemodialysis, I mean, we are literally, it would be like today it's 107, tomorrow it's 32. That's what it does to your body. It's just like, what? So dialysis is great, especially in an emergency situation, because by golly, you can correct problems. Because blood goes in all crappy and messed up, and it comes out the other end perfectly clean and shiny. Unfortunately, you have systems, which we're going to talk about over here, you have systems that are trying to correct the problem in the first place. And it takes them a while to change shift. So if you're giving them corrected blood, they're going to be going, what am I supposed to do now? Because I was doing this like you told me to do, but now you've corrected it all and I don't know what to do. And it takes a while for the body to uncorrect its corrected. When we're correcting things, in general, unless it's a life or death situation, when we're correcting things, we go nice and slow. We get the body right up to the line to where normal is, and then we stop. Because the body has mechanisms, and it's trying to correct it. Stop for a minute, my pants runs it. I have zippers. Where are those zippers? Thank God! And the good thing about the elastic is if I forget to tie them, they stay up. I just happened to one of those, oh crap, my britches are open. They're not. So when we're correcting, in particular, fluid electrolyte problems or acid-base problems, we get the body right up to the line of normal and then we stop. Because the body's going to keep going and finish the correction by itself. Does that make sense? Because if we correct it to normal, the body is still going to be trying to correct, and then it's going to overcorrect, and then you're way over on the other side. And then you go, oh, I've got to go back the other way. So we get the body right up to just about normal, and then we just let it do its thing. And almost always the body just figures it out and takes over. So we never will correct an acid base or a fluid electrolyte problem to perfect. You get it almost perfect, and then you let this perfect piece of machinery do the rest of the job. Okay, let's talk about sodium. The biggest are going to be your muscle cramps in the term of weakness, respiratory failure, which is pretty extreme, and then cardiac dysfunction because the cellular walls are all messed up. Hyperkalemia is muscle weakness, even worse than the cramps part in hypokalemia. And it's muscle weakness because there's too much potassium out here, and so you won't have action potential because the sodium isn't going to go across the cellular membrane if there's no reason to. What? We're talking about hyperkalemia signs and symptoms, right? Okay. Cardiac dysfunction, paralysis and respiratory arrest. Here we go again. Paralysis and respiratory arrest are going to be big things with hyperkalemia. And again, it's because I'm supposed to have most of my potassium on the inside and most of my sodium out here. But if I have a lot of potassium out here too, sodium has no reason to go across the cell membrane. So if it's not going to go across the cell membrane, I don't have any action potential. So too much potassium is going to just cause those cell membrane walls to go. Because there's no reason for the sodium and the potassium to go across. Because the potassium's all out here and in here. And the sodium is kind of like, well, I don't know what you want me to do. So, cardiac dysrhythmias, paralysis, respiratory arrest, hyperkalemia is a little more rough with your body. And again, IV bicarbonate, loop diuretics are good, but it's kind of a slow process. But again, we want it to be kind of a slow process. If it's an emergency, what do? Dialysis. Exactly. With dialysis, we can just take that away really quickly. It's very difficult on the body, but it comes down, I told you guys, I think I've said this before, but medicine, sometimes you have two crappy decisions. This crappy decision is, we let them keep going with this high potassium and we try to correct it slowly over time. This crappy decision is, and this has like a bunch of consequences, this crappy decision is we can put them on dialysis, we can clean this mess up, but then it's going to jack up a bunch of other stuff. So each patient is going to be a different approach based upon what other underlying pathophysiology is happening. So sometimes in medicine, you have two crappy decisions and you just got to pick the right one for that patient. Yes, ma'am?
So for patients that are in chronic renal failure and they're on dialysis 3 times a week, is their body constantly going through that
Balancing act?
yeah, like constantly, because they get it cleaned up and they go a couple days and do it again, and so it's hard on their body like basically every single day.
Yes. And your chronic dialysis renal failure patients are they're always a little bit in metabolic acidosis. No. But their body gets used to it. It's like, yes, sir.
I'm sorry, good job.
No, that's okay.
We have like a nephrologist at my job. A lot of times we get like critical values. She never wants to be called unless it's the potassium that's out of whack. Other than that, she's just like, don't call me.
And potassium is the biggest beast. It really is. That's why I started off with potassium.
She's like, that's all I want to know. What's
Yes.
potassium? Don't call me otherwise.
Yeah, and that's a great doctor, because they're the ones who aren't going to go, oh my God. The potassium is the one that's going to cause you the most problems. And again, crappy situation here, crappy situation here. You look at, and I keep saying this, what's going to kill my patient first if I don't fix it? And it just depends on that patient's pathophysiology. This one we might put them on hemodialysis and it'll kill them. We might give them Lasix and their kidneys will fall out of their bottom. So, two unfavorable decisions, but we have to figure out which one of these, if I don't do it, is going to make my patient die first.
Now, When my grandpa was under dialysis years ago, the fear was once he started, he wouldn't be able to stop it. What is the reasoning behind? Once they put him on, they were afraid that he would not be able, he would have to be on it for forever.
It depends on his kidneys. What is the underlying pathophysiology with his kidneys?
And they were crap.
And that's probably why. Because again, your body's gonna try to correct itself as long as it can, but you can only live in that state for so long healthily.
Mm.
So then, that's where putting them on dialysis, that's kind of like, that's, because you're gonna be starting to correct those problems, and you're just gonna have to stay on it. But her first than you.
Okay. I actually, I have a friend that, has, stage 4 kidney disease, and he was on dialysis for a couple of years and was actually able to come off of it, and his kidneys did correct itself, and then he went to stage 4 renal failure again.
Ugh. So again, which decision do we make? And was he
So
younger?
he was off dialysis for a while.
Was he younger?
He's like 34.
Okay. Yeah. So again, you've got younger, healthier kidneys, you've probably got more nephrons. I know you've got kidney disease going on, but again, you have to look at the patient themselves. Yes, ma'am?
So when you say emergency, because I know you said dialysis when in the emergency, when will you determine that it's an emergency? Is it more so off the lab? Because you know each person is
And
different.
the patient presentation. Is my QRS this big and my heart's going bonkers and I've got these terrible muscle weakness and I've got then that's a situation where we have too many bad things happening and we need to put them on dialysis to correct this. And you can do dialysis once or twice. I have had patients with drug overdoses and, it's like the trifecta. You have an alcoholic who's done a drug overdose, who gets in their car and takes off driving and crashes their car. So now we've got all this soft tissue damage, and we've got chemical imbalances in here, and that's one of those where you just put them on dialysis, and sometimes they just need like 1 or 2 or 3 dialysis sessions, and they're cleaned up. Because you get to the point where your kidney is so bogged down, your kidney's just like, I don't know what you want me to do here. It's like if I just keep giving you work and 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 keep giving you work, and I need done by Tuesday, which was yesterday. That your kidneys kind of do the same thing. They're just like, ugh. But, if you have this and you can kind of clean up some of the mess for them and get it back down to a tolerable level, then your kidneys will pick back up usually and clean up the rest of the mess. Again, you get the body corrected to almost normal, and then we let it finish the rest of it off. Now, you're never going to have an NCLEX question that says, what value are we going to correct the potassium to in a patient with this, this, and this? That's a clinical thing. Okay, it's time for a break. Well, it's time for a break because I'm about